Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, thanks for joining me for this week's special episode of the Healing Pain Podcast MasterClass, where we're discussing the impact of motivational interviewing on chronic pain. On this week's episode, I'm joined by Dr. Rose Pignataro, who is a doctor of physical therapy and an expert on how to use motivational interviewing specifically in physical therapy, chronic pain, and non-communicable disease. In this masterclass, Rose will discuss what motivational interviewing is, how motivational interviewing can be used alongside other treatments, such as exercise, pain neuroscience education, CBT or ACT, how to bill and code for this intervention in clinical practice. And then finally, she'll go through a case study of a woman with diabetic peripheral neuropathy who is ambivalent to start an exercise or change her nutrition patterns. Make sure you hang on for that because the case study is toward the end of the episode today. Dr. Pignataro has joined the Integrative Pain Science Institute as a faculty and educator. You can check out her latest course, which is Motivational Interviewing for Chronic Pain. After you listen to this episode, you can find it on the website at the integrativepain-science-institute.com and just scroll over to courses and go through our course list and you'll find it there. Okay, without further ado, enjoy this masterclass with Dr. Rose Pignataro. Let me introduce to you my good friend and colleague, Dr. Rose Pignataro. She is a doctor of physical therapy with more than 30 years of direct patient care experience, including the treatment of chronic pain and associated conditions. In addition to her clinical background, she has earned a PhD in public health with a strong focus on social and behavioral theory, health promotion and wellness. She's also certified as a health education specialist and certified in wound management. She's an associate professor and assistant chair of physical therapy at Emory and Henry College in Marion, Virginia. And of course, as you all know, Rose is leading the motivational interviewing course for chronic pain here at the Integrative Pain Science Institute. I'm going to put that link in the chat thread so you guys can take a look at that course and you can access it as we, let me get that to all panelists. As we talk here today, you can kind of look at that course and of course, access it afterwards. It is a course that's worth 7.5 CEU hours, CE/CEU hours. The Institute is an approved provider for physical therapists continuing education units, for OTs, for health coaches, and the Institute is an approved provider by the American Psychological Association. So for your mental health provider, that covers you there. So it's 7.5 CEUs. The course is currently priced at $299, which is an excellent value for what you're getting here with regard to working with Rose. And I've seen the back end of the course and the information is amazing. But before we kind of go on to that case study, let's go into just a quick Q&A, Rose. Is that good for you?
Sure.
Okay. So I think the most easiest place to start is how do you describe or how do you define what motivational interviewing is?
It's really, I guess the best way to describe it is that it's really a style of communication that's very patient-centered. And so it allows the provider to gain further insights into the patient's perspectives about why they're seeing us, what they expect to gain from the consultation with us or from continued treatment with us. Also, when we're talking about any type of behavioral change, it's very empowering for the patient because it recognizes them as a collaborative partner in their own care, which is something that we don't always see when we use a more traditional model of healthcare, where we're acting as the expert and kind of prescribing what the patient should be doing. And so with motivational interviewing, there's this bidirectional dialogue where we're asking the patient questions about their intentions, questions about what they see to be some of the issues that they could address through their own behavioral changes or by taking ownership of the health condition, what they see as some of the barriers to change and what they think are the best strategies to address those barriers.
So it's kind of I think an important word there for us to maybe talk about just for a moment is the difference between us educating a patient versus the professional promoting effective behavior change? Because I think all health professionals are really excellent at patient education, but really what you're talking about is enhancing that communication with some of these MI skills.
Yeah, I would agree with that for sure, Joe. It is a form of communication that's used for patient education, but there's a difference between instructing the patient in where I'm using a more prescriptive approach, which is sometimes appropriate, and using motivational interviewing, which is more, like I said, collaborative. You're really having more of a conversation with the patient as opposed to me just telling somebody what I think might be best for them. And so it really allows us to tailor our approach because what's best for me may not be best for you. So it kind of recognizes that.
That's great. I was going to kind of answer part of that because, as professionals, we study so many things in school. We're constantly learning new things in continuing education courses. And we always think we know what's best for the patient. We have the answers, so to speak. And what's the challenge with approaching a patient in that way?
Well, sometimes we do know what's best, right? I mean, you go to school for a long time and you continue reading journal articles and taking courses like the ones that are offered through the IPSI. And so in many cases, we are the experts, right? And that's why patients come to see us. But the danger in me always being the expert is that I could prescribe or instruct a patient in a certain set of behavioral changes or, exercises, something like that. And the patient doesn't necessarily have the capacity to perform or to adhere to those recommendations and know about that unless I provide space for the patient to talk about that.
Excellent. How does motivational interviewing help a physical therapist effectively treat pain specifically? So just kind of zeroing in on pain, how does MI enhance our ability to treat pain as professionals?
We recognize that pain is a multifactorial experience for the patient. And so there are physical and neurological aspects of pain, but there are also psychological aspects of pain. So it affects the whole person. And so I can do certain tests, right? Pain provocation tests, like certain objective measures, but that doesn't necessarily capture the full picture. And so more recently, as healthcare professionals, we've been encouraged to use like the ICF model of disablement, where we're looking at not only the physiological factors, but the contextual factors. And so unless I really ask very directed questions of the patient, I don't necessarily know, what type of support are they receiving from their significant other, from their family? What are their pain perceptions, perhaps? Like, do they think that they've done something that has caused this pain for themselves? Or do they have more of an extrinsic point of view where they think that the pain is coming from lack of proper treatment from the healthcare professionals, for instance? And so using motivational interviewing helps us gain insight and awareness of what this patient thinks, like what's causing the pain. Because if I think the pain is coming from, say, a mechanical problem in the spine, but the patient has some type of belief that the pain is perhaps coming from, the lack of proper pain medications, then we're not going to be able to come to a central agreement unless we start to talk about what the differences are in our perspectives. And each one of us gets to explain why we think the way we think. Good.
And just a clarification, the ICF stands for?
The International Classification of Functioning Model through the World Health Organization.
Good. Yeah, there's always a question about that when we kind of use a little abbreviation. So basically, it's a pretty good model for a biopsychosocial approach to treating people. That's become the mainstay for most professionals, and it continues to grow.
Right. I think that's a better actually term that you just used, Joe, that biopsychosocial approach. Yeah. Because the ICF model is again goes along with that medical perspective, and the biopsychosocial model tends to integrate more of a mind and body connection.
Yeah, excellent. So a big one, this always comes up with every professional, specifically PTs, because we have a lot on our plate in clinical practice. How, as a physical therapist, can I start to weave MI into practice? Do I have to have a lot of time for this? When people, specifically, obviously, when mental health professionals, they have their counseling all day long, if you will. And we, as physical therapists, counsel as well. But we're starting to now expand this and realize, okay, there's a lot of counseling that actually has to happen with regard to exercise and nutrition and promoting sleep and all the various things that all of us are talking about as professionals. But as PTs, do I have to have, an hour to do this? What does this look like? If you can talk to that a little bit.
Yeah. Although I spend most of my time now in the academics, I still treat patients. And so when I'm in the clinic, I have the same productivity standards as other people. I'm not getting extra time to treat patients with motivational interviewing. I use it when I'm going to do any form of patient education. And so it depends on what your intention is. Certainly, if I'm having a health coaching session, I'm not doing physical therapy. I'm using a full 45 minutes to use motivational interviewing to kind of get to the crux of the behavior that the patient needs to address. But during a PT session, I'm using more of a brief form of motivational interviewing, the same as I would do patient education. And so, I'm teaching somebody a home exercise program, and instead of using that traditional form of instruction, I'm using MI. So motivational interviewing, you can use a brief form of motivational interviewing where your main intention is to change the patient's perceptions regarding the usefulness of their behavior as it stands, and sort of encourage them to see their behavior in a different light so that it's more intentional towards recovery. And you can do that in as little as 5 to 7 minutes. And typically I'm doing that while I'm doing something else. So, I'm instructing somebody in a home exercise program, or I'm doing manual therapy and we have a chance to have a conversation. It's just being much more intentional in your communications. It doesn't really add time to the overall episode.
So it doesn't add time to your overall episode. And these skills are, I guess, informing, or it's kind of like the through line with your communication when you're working with your patient or client.
Right. Yeah, for sure. Like I said, it's really just being more intentional in choosing the topic of discussion and asking open-ended questions that solicit input from the patient, so that you're able to identify what's the next best step in the overall plan of care. And so, my treatment sessions are not any longer than the other therapists.
Right.
In fact, maybe it's a little bit of bias on my part. I think I'm actually more efficient because motivational interviewing has been shown in the evidence to enhance adherence. And so instead of showing somebody their home exercise program 7 times, I'm showing them once or twice and getting enough feedback where we're promoting adherence. So I don't have to keep repeating the same thing over and over again.
And I love that because your communication style and using these, tools that you learn through MI, you're able to make this concise, I think, which is important. Because so often even mental health professionals, I know I have some colleagues that work in primary care and behavioral health, and they only have 15 or 20 minutes with the patient, actually. So it's not just PTs, it's really everyone across the healthcare spectrum. Primary care physicians, I think, are a good perspective. But getting back to those kind of brief, really what you're saying is sometimes just 1 or 2 questions can really be the pivot point that starts to move the session and someone's behavior in the right direction.
Yeah, even during an initial assessment, one of the best questions that I can think of asking the patient is, what do you think is the best way to address the issues that we just identified? Because that will tell you whether or not you're on the same page, or, what's the reason that you came to see me? What is it that you hope to gain from our interactions with one another?
Excellent. So I mentioned earlier, I come across MI years ago, and I love it because it just blends well with everything. But can you talk more specifically about some of the research? What is MI shown to enhance specifically?
Well, it originated with 2 psychologists, Miller and Rolnick, and they originally designed it to work with people who had addiction issues, and to help those people recognize their own role in addressing the addiction. And so, it recognizes our self-determination as adults. I can't force another adult to do their home exercise program. I can't force another adult to modify their activities. I can encourage that and certainly use my own skills as a resource for that patient. But it's expanded from that initial use in addiction science to really any type of health behavior. And when we look across the American population and the high prevalence of non-communicable chronic diseases like hypertension and diabetes, cardiac disease, chronic pain, what we want to do is look at the things that can be changed. What are the modifiable factors? And when you look across the board at modifiable factors that are common to these types of chronic diseases, some of the big ones that stand out are diet and nutrition, exercise and lack of physical activity, so more of a sedentary lifestyle. Mm-hmm. And when we look at people with chronic pain, very often they've been disempowered just as a function of their impairment or disability. So this really helps them take ownership and control over that, rather than continuing to be dependent on the healthcare practitioner.
So, for example, does MI blend with pain neuroscience education?
For sure. Right. And so, one of the first things we want to figure out with pain neuroscience is what are the patient's pain beliefs, right? And so what does this person think caused their pain? Or what do they think is the best approach for treating the pain? And then we can talk from there. Motivational interviewing allows us to explain our rationale behind some of the recommendations that we might make and find out from the patient whether or not these recommendations seem feasible. So, a big one would be fear avoidance. So avoidance behaviors, the literature supports the fact that motivational interviewing is very effective in addressing some of those fear avoidance behaviors that stop people with chronic pain from being able to enjoy an active life.
That's so important because those fear avoidance behaviors are, of course, important for pain, but fear avoidance comes up in a lot of other types of conditions and areas as well. Anxiety, depression, even certain food and changing dietary patterns. People have lots of preconceived notions about food and how do we start to overcome that. So lots of different applications. A big one that comes in all the time with everything new is how do I bill for this, right? There's always productivity demands that are placed on us as professionals. And with that productivity, people are looking at, of course, how many patients are you seeing? And then what are you billing? How can you bill for MI?
Right. The same way that we bill for traditional forms of patient education. So, the CPT code for patient education, it's 98960, that can be used for motivational interviewing. Or if you're running a session where you're educating somebody, for instance, in different forms of therapeutic exercise, then you use that billing code. So like 97110 for therapeutic exercise. I'm doing therapeutic exercise combined with motivational interviewing.
Right. Because ultimately, within that 15 minutes of a time code, let's say, so Therex, it's not like the person's just exercising for 15 minutes and you're just sitting there as a professional.
Right.
You're educating them, guiding them. And in the context of MI, you're helping to sustain and motivate that behavior for the long term, basically. And it's so interesting because I think as professionals, we're naturally good at creating these therapeutic bonds and just, being chatty with patients, so to speak. But this is really saying, okay, how do we kind of really zone in on what's important here, which is the behavior change, right?
Right.
Yeah.
I mean, that you're hoping for a lasting change of behavior so that when the person finishes that episode of care, they're autonomous in managing the condition. And so, the other thing is that we face a lot of restrictions that are secondary to payment, right? And so, maybe you think that the patient needs 24 visits, but you only get 10. And so by being more efficient in the way that you are kind of guiding the patient's care and in promoting adherence, you're getting more out of the sessions that you are allocated to with the patient.
Do you use MI skills when you're implementing, let's say, manual therapy techniques?
Yeah, for sure. It helps the patient know why you're doing what you're doing. Also what the end goal is. It encourages the patient to give feedback, right? We often hear the term passive treatment is I have hands on the patient, but it's not really a passive treatment if the patient knows why we're doing it. And the fact that this is kind of a temporary step to make them more active. I want to make them reliant on joint mobilization or soft tissue mobilization, anything like that. It's kind of a means to the end, right? And so if I can do these manual techniques to help you be more physically active, that's the goal. The goal is not to see how good my hands are and how good my manual skills are.
Right. So from a PT perspective, we can overlay with manual therapy codes.
For sure.
Therapeutic exercise, neuromuscular reeducation or therapeutic activities.
Yeah, neuromuscular reeducation is a big one. Like if you're doing lifting techniques, body mechanics, that kind of thing, gait and balance training,
Anything related to self-care.
For sure.
Good. And then just so people know, there are behavioral health codes that any practitioner can use and access, whether you're a PT or whether you're any other type of practitioner. Those behavioral health codes, so it's 96158 and 96159. 96158 is a 30-minute code, and 96159 is a 15-minute code. So those are codes for adaptive behavioral therapy. It is, of course, up to the insurance company. There's in the country we live in, there's hundreds and thousands of insurance companies, but many, many companies will reimburse for 96158 and 96159 for adaptive behavioral therapy. That includes PTs, OTs, people out of the mental health realm. So we're going to start to wrap up the Q&A here. I, of course, encourage you to put some questions in the Q&A part there, and we'll answer those at the end. But I want to start to turn toward the case study that Rose is going to chat about for probably about 20 minutes or so. But as she's talking, you can put, as I mentioned, questions in the Q&A there. Okay, so without further ado, let's turn that over to Rose and she'll go through that case study.
Yeah, before we go through the case study, there was a good question in the Q&A in the chat. Someone asked whether or not motivational interviewing can be used during the examination. And yes, I start using it from the very first encounter with the patient, right? And so often in the initial encounter, we're explaining to people what we're doing, what we can offer them as a healthcare practitioner. So why we're doing what we're doing. Also making the patient an active participant. As I mentioned before, what do they think is causing the pain? What might they think is the best way of going about this? So yes, it can be integrated into the examination. And very often that is what happens from a chronic pain perspective, right? And so, if we're thinking that weakness has contributed to the person's chronic pain, that's where you start talking about that for sure.
Yeah. Once I learned MI, I even changed my intake paperwork. Mm-hmm. To ask questions that were more in line with, good behavioral principles.
Yeah, we do that with the wound care intake as well. One of the questions on the intake form is, what do you think caused this wound and how long do you think it will take to heal?
Yeah, that's interesting. What are some of the responses that people get? So when you ask them, what caused this wound and what's the path you think you should take to healing? What are some of the responses you get toward that?
Sometimes the patient doesn't really know what caused the wound because my practice is usually around chronic wounds. Mm. So then that tells me that I kind of have, a harder job because especially if somebody has for instance, a neuropathic foot ulcer that's been caused by diabetes and that person doesn't see the diabetes as a contributing factor, it's hard to get that buy-in from them because as part of their treatment, I'm going to recommend better dietary control, better blood glucose regulation. And if the person doesn't think that that's a contributing factor, I'm not going to get the adherence that I would like to see.
Good. Okay. So let's hold the rest. So keep putting those questions in the chat there. We're going to come back to them. So keep popping questions in the Q&A there. But I want to turn to the case study so we can make sure we of course want to make sure to squeeze that in here. So let's begin with the case study.
Right. And so I just want to make it clear for HIPAA purposes. So for patient privacy, I've sort of conglomerated a couple of different patients so that I'm not violating anybody's confidentiality. And so the case that I've discussed with Joe is that because I am a wound management specialist, very often I'm seeing people with chronic pain that's related to diabetic neuropathy, for instance. And so in the case that I'm going to discuss, we had a patient come to us with very painful diabetic peripheral neuropathy that had affected both her hands and feet. And it's good that we were able to get the referral as a preventative measure. And so it's actually, I'm sure it doesn't feel pleasant to the patient, but I would much rather see somebody with painful diabetic neuropathy than somebody who has lost their protective sensation, because once the pain goes away, then the patient becomes much more vulnerable to injury and not being aware of that injury because of the lack of sensory input. So this particular patient came to see us with pain in the hands and feet. I was already kind of behind the 8 ball because on the referral for physical therapy, it said for pain management using electrical stimulation. And so the healthcare practitioner that had referred the patient for physical therapy kind of already placed an expectation in the patient's mind that involved a passive form of treatment. Here, the patient's coming to see us and they're expecting to get a TENS unit, which I did think would be helpful. But based on science, right, the most helpful thing for diabetic peripheral neuropathy is blood glucose regulation. And so one of my first questions to the patient was, what did she think had caused the pain? And she said it was because the provider had taken her off of her pain medication. And so she thought that the best way to treat this would be to go back on the pain medication. And certainly we could see why that would be somebody's perception. And at the very least, if we weren't going to put her back on the opioid medication, then we needed to provide some other form of treatment like the electric stim. She also didn't think that the electrical stimulation would be effective. And so now she's coming to see me reluctantly just to prove that physical therapy can't help. And, with that knowledge, then going back to the doctor and saying, see, I tried this and it didn't work. And so knowing that that's where she was starting out, I was able to use motivational interviewing to see whether or not she thought that there were other contributing factors. And so we talked about the fact that it's called diabetic peripheral neuropathy. And so clearly through the name, you think that the person's diabetes has contributed to the problem. And so what could we do together to address the diabetes and not just the pain? And the first thing was that the patient was not testing her blood glucose level on a regular basis. And she didn't think that mattered. And so, theoretically, it may not matter, right? There's people that do have good blood glucose regulation and still have neuropathic pain. But this person had a hemoglobin A1C that was close to 9. And so we know that there's not good blood glucose regulation. And so I was able to use MI to kind of teach the patient about what her lab results meant so that she could track her lab results. And see how her behavior may or may not contribute to. Instructed that she needed to check her blood glucose levels 4 or 5 times a day. And so that's not going to happen with somebody who's never done it before. It felt very overwhelming to her. So we negotiated a midpoint. What if she checked her blood glucose level once as a starting point? And so I used motivational interviewing to ask the patient when, given her schedule, would it be the easiest for her to take her blood glucose? And she said in the morning when she woke up. So we use that as a starting point. Then through motivational interviewing, I found out that she was never really taught how to use the glucometer well, and that she feared pricking her finger. And so we were able to use modeling, which is a component of social cognitive theory, so that I did the finger stick on myself, and then the patient did her own. And so we did that a couple of times in our sessions with one another until she felt capable of doing that at home. And then once she was starting to use her blood glucose log and seeing that whatever she had eaten the day before had an impact on her morning readings, she was more willing to talk a little bit more about glycemic management and diet. And so I did a little bit of that with her, but we also have to remember that our scope of practice and the fact that we're part of an interprofessional care team. So who else can we collaborate with? And so we worked together with a dietitian who also uses motivational interviewing. So that worked really well. And she helped the patient create a food plan that went along with the patient's food preferences, which she knew about by using motivational interviewing. And the patient gradually started to see a better window for her blood glucose regulation. It took quite a while before the blood glucose regulation had an impact on the patient's pain level. And so that's the other thing that we needed to keep in mind. This is not a quick fix. And so in the interim, we did start using electrical stimulation. So she went home with a TENS unit and was able to place the TENS unit on the spinal segments to the hands and feet and get some relief that way. So she did become less reliant on pain medication, a little bit more reliant on the electrical stimulation, but ultimately was able to recognize the value of glycemic management through her diet and also by adding exercise. And here, the important component of adherence was that her exercise preference and my exercise preference were not the same. And so, we know what the textbook recommendations are, and I'm aiming for 150 minutes a week of our aerobic activity consistent with the American College of Sports Medicine recommendations, but that's not feasible. Somebody who's never exercised before is not going to do that. She also didn't like to walk because walking increased the pain in her feet, which was understandable. And so we finally were able to come to a compromise where she was on the new step, which is sort of like a seated stair climbing machine. That she didn't have one of those at home. So then we had to kind of transition to something that she could do at home. And she picked a walking video. And so that was one of the steps that we took with MI. I asked the patient, what do you think would work well at home? She said she didn't know. I asked her to kind of search some of she was an Amazon Prime member. So she went on Amazon and looked at some of the exercise videos until she found one that kind of suited what she felt were her capabilities. And my goal is just to get the patient to be more active. And I don't really have a preference for how that happened. So.
Good. Lots of great information there. So how did, are you still seeing this patient, or was she discharged at a certain point?
No, she's been discharged, but she does have, like every once in a while, she'll have a periodic wellness visit with us to kind of go over her glucose log, to talk about any types of barriers that might have come up. And that is a step in motivational interviewing. So we arrange for follow-up with the patient to kind of, first of all, she's done amazing. So you want to affirm how well the patient's doing, right? Because people like to be recognized for overcoming challenges. And she's overcome a ton of challenges. She's down something like 50 pounds. And so being able to affirm how well she's doing, it helps to continue adherence and to make sure that the patient feels heard and recognized. And then there's been some bumps in the road along the way. She did get a blister on her foot at one point that needed to be addressed so it didn't turn into a wound. So that was one of the barriers. The other thing is that she moved, and so she was kind of out of her circle in terms of social support and the types of foods that might be available at the local grocery store. And so we talked about the best ways to overcome that. And, the interesting thing about motivational interviewing is that it helps address people's self-efficacy. So that's confidence in your own ability to change. And because she became so confident in her ability to change her diet and her exercise habits, she's now tackling her tobacco use as well. But once you gain confidence in one area, it kind of spreads over, it carries over into other areas of behavior.
I was going to say 50 pounds is a huge success.
Well, we initially started with a 10% weight loss goal.
Yeah, which is what the evidence recommends.
Right. Yeah. So, once the 10% was achieved, then again, her self-efficacy increased and she continued setting incremental 10% goals.
Good. So I just want to highlight some notes that I took for everyone who's listening. Of course, Rose, you can test me on this, so to speak. But what I heard from this case study was that you had a patient come in who had probably lower health literacy with regard to what was the cause of their diabetic peripheral neuropathy. They were somewhat ambivalent about the condition itself and knowing what types of changes to make. What you really achieved through using good MI skills was taking that HbA1c, and instead of looking at it like a snapshot in time, is helping her realize. You mentioned the word panoramic, and for those that have taken my nutrition course, HbA1c is a long-term look at glucose regulation over time. For people with significant diabetic problems, oftentimes it's one of the most important aspects of it. Through that, you've helped her monitor her glucose. As she started to become more aware of her blood glucose on a daily basis. She was more likely to make changes to her diet, which you help coordinate into professional care with regard to a dietitian. However, many of us do not work in those types of environments, so we might have to do that ourselves, which is fine. With that, there was a decrease in pain that came later on, but that's normal, right? A lot of times what we find is we change the behaviors first and then pain comes later. She was less reliant on pain medications. She was more likely to exercise. And I think the most important part of that is you were able to help her figure out her exercise preference. Because once someone figures out the type of exercise that they prefer, they're more likely to continue with that long term.
Right.
Good summary.
Right. One of the things I did want to mention is, we have to be careful about the words that we choose to tell somebody about what's caused their pain. And so this person was told that she had nerve damage, and she did. But once you hear the word damage, you assume that it's permanent. And so that was part of it as well. If I'm telling you that something's permanent, then that takes away the patient's empowerment in a way, because if it's permanent, what can I do to change it? Right. Mm-hmm. It took a while to explain that, even if it were permanent, it could be progressive. So at the very least, you're stopping it from getting worse. Best case scenario is that it would get better, and that, because nerves heal at such a slow rate, if it was going to get better, we'd have to be patient with it. It would get better over a longer period of time. And she understood that, and it did in fact get better.
Yeah, that's so important. So looking at patients' beliefs around their condition, specifically this related to nerve pain. Mm-hmm. And I think also, people come to us and they think, well, you have the knowledge, you have the skills, you're going to fix this for me. And what I like about MI is it's a really compassionate, caring way to kind of turn it back to them and say, hey, everything you need resides in you, actually. Everything that you need to heal yourself and start to reverse the pain and the chronic condition that you're dealing with, whether that's a specific chronic condition or whether it's a non-communicable disease or a mental health condition, all that resides in you. I'm just going to help. I'm going to walk side by side with you. I'm going to help facilitate this for you. And together we can do this.
Yeah, I would agree. It's very empowering. It puts the patient back in the driver's seat. And so, you have to think about too, when you're working with somebody who has chronic pain or a chronic condition, that person has likely tried to change their behavior before and they've been unsuccessful. So with this person, she had been overweight for most of her adult life and had tried unsuccessfully before to lose weight. And so that affects people's confidence in themselves as well. I've tried this before and it's not been effective. What makes this time different? It's incumbent on us to show the person that they are capable. And that's usually done gradually with progressive goal setting and small incremental achievements.
I want to turn to the Q&A, and I'd love to hear from you. If you want to chat with us, you can raise your hand, and I'd love to, chat with you one-on-one. And I'm sure Rose would love to chat with you one-on-one also. So if you want to raise your hand there, and we'll come over, and I believe we can chat with you here through this platform. And I see Scott there. So let's go to Scott first.
Scott, can you go ahead and tell us?
All right. Hey there. I'm a chiropractor. I deal mainly with people coming in hurting. How can motivational interviewing help us steer the ship a little bit more away from people's immediate pain concerns? We know that, for instance, something like low back pain is not something that we're going to magically make go away with some, in my case, miraculous adjustment or putting a bone back into place or any of this stuff. How do we help them with that to be able to see it in a broader context?
It's a great question. Often it comes down to what's the patient's perspective, and it may not be reasonable or realistic to completely get rid of someone's pain. And so what's an acceptable level of pain relief for them? Or can we use MI to steer them away from using pain itself as an outcome and maybe using their functional level or ADL as an outcome, their activities of daily living? And so, aside from pain relief, what is this person hoping to achieve by coming to see you?
Mm-hmm. Okay. Yeah. Thanks. I mean, it's that whole thing of getting stuck on the pain
Right.
both the practitioner and the patient is yeah, it's tough.
It is very tough. But, the other thing is, like, if it's not feasible to get rid of the pain completely, where can this person function, right? And so you have a chronically painful condition and you come in to see one of us and your pain is at a 7/10. Well, we can kind of understand why that person's unable to function. But, just helping someone understand that it may not be realistic to get rid of the pain completely, but if we're not able to do that, what's the best possible outcome that they can imagine? If that person says 4/10, well, then, we probably can work together to get to that point.
Mm-hmm. Thank you.
Thank you.
Great question.
Mark Powell says it seems like MI can be used without being billed in and of itself, if it's simply used briefly to enhance the more primary method that you're using with a client. And I would agree with that, but it can be billed in and of itself. Like when I'm doing diabetes education, it gets billed in and of itself as diabetes education. I'm not doing any type of manual therapy. I'm not doing any kind of therapeutic exercise with the patient. And so there are times when it does get billed by itself as its own intervention.
Hi, thanks. I'm a physical therapist who works exclusively with chronic pain patients, and I wondered about how or what kinds of questions I can ask to help. Sometimes I have patients who, they are they exercise excessively. Like their pattern has been, they were 100 miles a week in biking, and they go to the gym and they're going at max heart rates and that sort of picture. And so they're not seeing really that exercise because it is so, and it's an accepted form of self-care, right? Why would you ask me to cut back on that or even to try and clear that plate? It's a healthy thing for a lot of reasons. And so, and I work with a team. So I have a psychologist, a nurse, and so there's a whole team of us just looking at all these aspects. So it's a hard one because it's really viewed as a healthy thing to do, right? But they're not seeing it as contributing to their pain. They'll tell me, well, I really don't feel that that it makes a difference. I think it makes me feel better. And so that's a hard place for me to work with people.
I think it'd be a hard place for any of us to people. Again, MI is not like this magic wand. It's sort of
right.
This negotiation that occurs between the practitioner and the patient. And so, can you get that person to, first of all, what do they think is causing the pain? And if they're not seeing the exercise as a contributing factor, would they be willing to maybe give it a try, right? And so would this patient be willing to cut back on their exercise and see on a trial basis whether or not it had an impact on their pain? Mm-hmm. Not the exercise, what do they think they can do on their own that might give them greater pain relief?
Yeah.
Allows us to explain the rationale behind, if I tell somebody to stop exercising and they think that's what's making them better, I have to be able to explain why I think that's contributing to their pain.
Mm-hmm. Mm-hmm. Okay. Yeah. I think probably the hard part for me too is because the model that I work in, they really want, a part of it is really clearing the slate, just trying to start from a baseline where there's room for them to do mind-body practices where they slow down enough to be able to feel themselves again. And so even if I need to cut them back, my job on this team is to cut them back enough that there's that kind of space. And so, I'll try to give them something that is an alternative movement or an alternative way to move their bodies. And the argument is that's just ridiculously slow. It's just not going to actually help me. I'm going to be in more pain. And but I hear what you're saying. It's a negotiation is kind of what I'm getting from this, and just really trying to understand, trying to maybe incrementally try the most incremental approach that works. That I can.
Yeah, I mean, it's about us recognizing the patient's perspectives too. And so, can you, from your perspective, see why the patient would think that exercise would be beneficial? I mean, that's what we give people all the time, that exercise is good for your health. And now I'm telling you not to exercise. It's contradictory.
Right.
Would they be willing to cut back and see where that takes them and acknowledge the fact that we could be wrong, right? So maybe they cut back and it's not better, but at least we've ruled something out.
It's a really interesting question, because we're talking about taking a healthy behavior that all of us are looking to promote typically that can be challenging. But in this case, what Judy's talking about is the patient's already adopted exercise as part of their lifestyle, except we're either looking to reduce that healthy behavior, because sometimes a healthy behavior can not be healthy, right? If you sleep too much, actually, if you look at the studies on sleep, if you actually sleep too much, the reverse effect happens, right? It becomes paradoxical. And the same thing happens with exercise. So I'm curious, Rose, if with this particular case, knowing that this person does value exercise and it's part of their life, can we help use MI skills to help them become curious about other types of exercise, not just, let's say, the high intensity, but realize there's also a place for lower intensity exercise or moderately intensive exercise?
Right. I think that's where Judy was going when she was talking about mind, body, and bodily awareness. A lot of times people that are high intensity exercisers, or maybe like endurance athletes, people that are used to performing at a very high level, part of their pattern is ignoring signals from their body, right? They push through the pain. And now we're trying to get them to be more aware of those signals and more responsive to those signals by picking an alternate activity. And so, I think, Judy, did you mention yoga?
I didn't mention it. But yeah, we also have, a person on our team who teaches that. It's, so yeah, I love the way you framed it though, Joe and Rose. I'm just getting a different frame, I think is what it is. To be able to really acknowledge that the value of the exercise, also trying to find why they value it in their lives, how it fits in their lives, but considering an alternative. I think alternative is nice, just really emphasizing the alternative part. And also just like the monitoring of the glucose, taking a while to actually kick in to see a difference, just being able to support them through a time where they might not see it, but they just have to have a little confidence that we're just going to try it and try to really find or acknowledge and affirm, highlight even the small notices, the small awarenesses, because I think that would be very helpful. So, yeah,
and even just getting used to paying attention to signals from the body or connecting with your body in a different way.
Right.
People with chronic pain, they're used to connecting with their body in terms of kind of negative feedback, right? I have pain and I'm aware of the pain, but I'm not aware of all of the other positive things that come from bodily movement or bodily awareness. That's where the mindfulness practices and the yoga really come together with that to help people connect with their body in a more positive way.
Right. Okay. Thanks.
Good. We're going to, I just want to answer, there's a question in the chat thread here I want to answer from Rachel. And her question is, as a massage therapist practicing outside of a healthcare or insurance environment with questionable scope of practice to make suggestions about outside activity, how is MI useful in session or ongoing for treatment? I just want to make a point to everyone that motivational interviewing has been around for quite a while, and it's been employed by licensed health professionals. It's been studied in fitness professionals, and it's even been delivered by peers. So people with absolutely no healthcare training at all or any fitness training, it's been delivered in those types of formats at all. So MI is crucial for really anyone working with anyone where you're looking for behavior change. And I'll tell you, just as an aside, like once you learn good MI skills, you use them in your personal relationships. You use them in communicating like with anyone you're talking to. And those skills come in really, really handy in many, many different places.
It's a great point, Joe. I think it just makes you a better listener. At least I know. That's true for me. That part of MI is using what's called reflective listening. And so, not only listening to the person in preparation for you to generate a response, but genuinely listening so that you are interested in what that person has to say and how they view the world, and then asking follow-up questions that sort of reinforce that.
We just have a couple of minutes here, Rose, to wrap up. Can you give us a kind of an overview of the course? So, of course, it's called Motivational Interviewing for Chronic Pain. It's 7.5 hours CE/CEUs. Can you just kind of talk to us about the course a little bit?
Mm-hmm. So for me, motivational interviewing is not only about the technique, but the underlying social and behavioral theories. So something that we call motivational assessment. And so part of MI is understanding where the patient is coming from. Like how do certain theories contribute to the decisions that we make about our own personal behaviors? So I mentioned self-efficacy. That's a component of a lot of behavioral theories. Also, what forms our intention? How do other people's attitudes and our own attitudes affect our intention to perform a certain behavior, our intention to adhere? So that's part of the course as well, like doing motivational assessment, looking at readiness to change. What do we do if we have a patient that's very resistant to change? What do we do when we have somebody that's already engaged in change and maybe just needs some encouragement or some redirection to make their behavioral change more effective or lasting? Also, how does motivational interviewing fit in with some of the chronic pain models? How does it complement some of the other interventions that we might be using, like the mindfulness practices that we just talked about? What are some of the psychological perspectives that come into play, like the fear avoidance behaviors, but also things that we don't typically, at least for me, haven't typically considered, because I'm coming at things from a very structured physical perspective. Even things like adverse childhood events. Everybody has baggage. So what types of packages is the patient bringing to you in their healthcare encounter, and how do we help them unpack that to see how it has an impact on their physical health?
Very good. So I placed the link to the course in the chat thread there. You can find the course as well at the homepage on the Integrative Pain Science Institute. Just go to courses and you scroll down. You'll see it there. And just a little bit of a quick screen share here, just as we look at the course, just to look at the course outline for a minute. Again, it's 7.5 hours of content, so 7.5 hours of CEU. Week 1 is the foundations of motivational interviewing. So it's the how and why MI improves pain outcomes. Week 2 is motivational interviewing for health behavior change. So looking at cultivating collaborative and patient-centered communication. Week 3 is the spirit of MI, inspiring and sustaining a commitment to change in behavior and a change in pain. And finally, week 4 is tailoring MI-specific techniques. So creating personalized action plans to successfully manage pain. So with all my courses, once you buy the course, it's the same with Rose's course. Once you purchase the course, it's yours. You can go through it at your own pace. You have it for as long as you need to have it for. The course is $299 today and today only. And as I mentioned before, it's an excellent course. I've seen the content on the back end. It's very concise. It really provides you with everything you need to get started. And, I've known Rose for a while now, and just between her clinical education, her education and her PhD around this topic, and her background teaching professionals how to use this already, it's really a win-win for everyone, whether you're a physical medicine professional or a mental health professional. So we're going to wrap up. This will be available for a replay if you want to watch it. We'll send the replay out. I'm also going to publish this as a podcast next week. So if you're following along with the Healing Pain podcast, please do follow along, and you can listen to it there as well. It'll be out next week. So any closing comments or suggestions you want to make, Rose?
No, just that, I really have enjoyed working with you, Joe, and I hope that everybody will enjoy bringing a different perspective to chronic pain management. I think it complements the other courses that you have through IPSI as well. So
it does. Motivation interviewing is great if you're working on, of course, changes in exercise, changes in nutrition. If you've taken my ACT course, there's a significant amount of similarities or I should say complementary aspects of ACT and MI, especially with regard to values-based care. So if you're in the ACT course or the mindfulness course, you're really going to find once you learn MI, it enhances everything, not only your patient communication and your skills, but it enhances all the other techniques that you've had for your entire career. All right, we're going to wrap this up. It's just about 12:04. Rose and I both thank you, and we look forward to seeing you in the course. If you have any questions, you can, of course, reach out to us at the Institute. You can send us an email at support@Integrative Pain Science Institute. That's support@Integrative Pain Science Institute. Again, I want to thank all of you for joining us on a Saturday. Enjoy your Saturday. Have fun with your friends and family and loved ones. I want to once again thank Rose for her incredible knowledge and sharing of information here today. I learned so much, and I know you're going to learn a ton when you join that course, Motivational Interviewing for Chronic Pain. All right. We'll see you soon. Take care.
Thank you, Joe. Thank you, everyone.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.